So it's my pleasure to introduce the next two speakers for the next panel. And we'll follow the same format as we did with the first panel. We'll have the speakers speak, and then we will have them come up front and do their a bit of a panel discussion afterwards. So we have two good colleagues speaking now. First, we have Dr. Lynn Friedman, who is a professor of population family health at the Mailman School of Public Health. Dr. Friedman directs the Averting Maternal Death and Disability program at the Mailman School. It's a global program of research, policy analysis, and technical support that has, since 1999, worked with UN agencies, NGOs, and government in more than 50 countries around the world. Before joining the faculty at Columbia, Professor Friedman worked as a practicing attorney in New York City. She has published widely on issues of maternal mortality and on health and human rights, with a particular focus on gender and women's health, and she serves on the advisory board of maternal health projects throughout the world. And then we're going to have Dr. Karen Lee, who's currently Global Healthy Built Environment and Health Policy Advisor. Dr. Lee works with governments and NGOs throughout the world on issues related to the built environment and chronic diseases. She's a special advisor to WHO offices on these issues. She's also a senior advisor on built environment and healthy housing to New York City's Department of Health. For the last 8 years, Dr. Lee has been the lead in the New York City Health Department, working with 12 agencies and non-government partners in the development and the implementation of the active design guidelines, about which we have heard several times already today. She was a key organizer of New York City's annual Fit City Conference since 2006, and helping other jurisdictions throughout the world, ranging from London all the way through to New South Wales, Australia, and Sao Paulo, Brazil, at developing their own Fit City conferences. It's my great pleasure to introduce Dr. Friedman. Dr. Lee. Lynn.
Let me just start by again thanking both schools and departments for this opportunity to be part of a conversation that for me is a very exciting one. I have to say, working on this topic for the last few years, the deeper I dove into the public health part of this, the more I found myself coming up for air really in the urban planning literature. So for me, it's been a kind of exciting discovery for myself, and I really look forward to the future of this conversation. So this morning, I'm going to talk about a case study involving childbirth in slums in Bangladesh, and I want to consider how the dynamic slum population dynamic slum environment, the social, the political, the physical environment of slums, in this case in Bangladesh, how they both constrain and facilitate women's choices and women's aspirations around childbirth, and how that relates both to health, but also to their rights and entitlements. So this will be something of a case study of BRAC. BRAC is an organization that I'll talk about in a minute, about their program that was called Manoshi, which was a slum-based maternal newborn health program. And the ideas I'm talking about today were based on about multiple years of work with BRAC and this program, but then with a year-long so-called realist evaluation to really try to understand what was happening in this very large health project. So before I get there, let me do first a few quick preliminaries about the Bangladesh slum situation, just so everyone kind of understands the context I'm talking about. So first of all, BRAC is the largest NGO in the world, actually, the largest non-governmental organization in the world. They have more than 100,000 employees before we ever start talking about volunteers. And it was started in the wake, literally in the days after the Bangladesh Liberation War in 1971. Then it was stood for the Bangladesh Rural Advancement Committee, founded by now Sir Fazlul Hassan Abed, Sir Abed. And this quote from him is very famous. It is the value that underlies BRAC, that people are poor because they are powerless. We must organize people for power. They must organize themselves in such a way that they can change their lives. And indeed, that's really what BRAC's story since 1971 has been about. It has massive programs, as you can tell from its roster of employees, working in microfinance, livelihoods, education, health, many areas built around village volunteer organizations. For the health people in the audience, they pioneered ORS, or oral rehydration salts, and made it really possible for mothers in villages everywhere in Bangladesh, every corner of Bangladesh, to treat diarrhea in their children and really save truly millions of lives. The second background point, childbirth in Bangladesh. So traditionally in Bangladesh, women give birth at home. They give birth at home, surrounded by basically a female support network of family, mothers, sisters, aunts, friends, and usually delivered by a TBA, that is a traditional birth attendant. An untrained local woman who probably does many, many deliveries. Although that is also starting to change. So for example, the demographic and health surveys in 1993 showed that about 10% of women in all of Bangladesh gave birth at home. And most recently, a couple years ago, it was up to 30%. Sorry, I said 10% give birth at home. Is that what I said? I meant in facilities. Okay, 90% give birth at home, 10% in facilities, and that's changed a little bit globally. I'm going to do a quick thing and just say that for maternal mortality and newborn mortality, but especially maternal mortality, that is death in pregnancy and childbirth, the trick, the key, not the whole thing, but the shortcut key is that when a woman experiences a complication that can threaten her life, she needs access to health services. Prevention does some things, but not a lot in this area. So unlike most parts of public health, where, as Linda said, prevention is the name of the game, in this one, it's different. Access to the care, it's not complicated care, but access to the care that can save your life is actually key for the reduction of mortality. A third background piece, urbanization in Bangladesh is happening very, very rapidly. At independence in 1971, less than 10% of Bangladesh was urban. By 2050, they anticipate that more than 60% of Bangladesh will be urban. About 1/3 of all people who now live in cities in Bangladesh live in slums, and slums by the kind of official definitions. Many of these slums are informal. That is to say, they are on land to which the occupants have no claim, or they occupy that land illegally. When you live in an informal setting, everything about your life is illegal, not just the land or the house you live in. So getting food often entails illegal transactions. Getting electricity usually implies tapping somebody's wires, often for money. Getting water, getting sanitation. In short, we can think about it as just making sure you get the basic needs of survival become criminalized, actually becomes illegal. So massive numbers of people in these settings live in that kind of situation. And there are massive numbers of people. Just to give you an idea, in Dhaka, the capital of Bangladesh, the density of population is about 250,000 per square kilometer. By comparison, in New York, it's about 10,000 people per square kilometer. Okay, 250,000 versus 10,000. That gives you a little feel for what we're talking about here. So recognizing these dynamics, BRAC, that was very much a rural organization, decided they needed to start looking at cities. And so they began with this program called Manoshi. And they started I don't know if anyone here's ever been in Bangladesh, but if you have, you've probably seen this slum called Karail, which is, I think, one of the biggest in the world. And this is taken literally from the window of the BRAC office. And Karail's this slum right here. And in about 4 years, BRAC-like, they went from that one slum in Karail to thousands of slums in Bangladesh and covering 6 cities and 6.3 million people. So this is sort of the definition of scale up in the public health world. The program built on the traditional BRAC rural structure of using a community health worker who visits people in their homes and delivers health messages and some simple health services. So this Manoshi program did many different things: antenatal care, prenatal care, postnatal care, nutrition, immunization, health education, many different things. I'm going to focus now, for the purpose of making a point, I hope, about urban space and health. I'm going to focus on delivery, childbirth, and delivery care. So when we think of this, we have to think about women who are coming in huge numbers to cities, to slums, from traditional villages where their families have lived for generations and generations. So they come detached from these traditional support networks that would support women in childbirth into a slum setting, usually in a nuclear family situation rather than an extended family of the village, with basically none of those traditional supports. They come in a way completely alienated from the formal health structure, to the extent there is one. It would be almost unimaginable for a woman in a slum in Bangladesh to just waltz into a hospital there and think that they would get care in the way you would here even in a crowded emergency room. Essentially, the formal health system is closed to the women in places like slums in Bangladesh. So in this context, at the start of this Manoshi project in 2007, in its catchment areas, 86% of women gave birth at home. And at home, as you'll see in a minute, means just a one-room corrugated metal shack, usually pitched over a fetid swamp water, in a very densely populated area. They gave birth at home with no hygiene, no privacy, not attended by a trained person, and very much and very often exploited by unqualified providers, so-called pharmacists, medicine sellers, etc., in the slum area. Research shows they relied mostly on their landladies for advice, and essentially they had no choices. So into this setting, BRAC came, and they built something that would be totally contrary to the global advice about where women should give birth, and that was, they built delivery centers. They first called them birthing huts, and essentially all it was is 2 clean rooms in the slums, very close to where people live. But they were clean, there was privacy. You can see there was a mattress on the floor, and they trained traditional birth attendants, called them urban birth attendants, to attend these deliveries. This is totally contrary to global advice because it wouldn't do anything to save somebody's life in and of itself. However, for women in the slums, it was a first stop where you could link to a health system. And what BRAC did is they also created a referral system. So for the health workers who staffed these, there were a series of different strategies that would enable the workers in these birthing huts in the slums to move women in case of an emergency as quickly as possible to a hospital. And the key thing here is the thing in red. BRAC actually posted one of their own employees at the door to the hospital because typically, almost 100% of the time, if you get to a hospital in Bangladesh, you are assaulted by what translates into brokers who basically try to steer you for money into different health services. And for poor women from a slum, you never get anywhere, and you probably even pay more than a wealthy woman. And by the way, maternity care should be free according to policy. So the key thing is that BRAC posted somebody 24/7 at the hospital, connected through a cell phone network, so that when a woman was transferred through BRAC-facilitated vehicles, there was somebody who could actually act as a systems navigator and get her access to the care that could save her life. And look at the impact. Yikes. So I hope you can see this from a baseline in which 86% of women in their catchment areas gave birth at home and 14% in a hospital. Over just actually 3.5 years, this quickly changed from 86% at home to 19% at home. I mean, that is a massive, I think any of the public health people here will agree, that is a massive change. The really interesting thing here, and the key thing, is that it started out with many people going to the so-called delivery center, the BRAC birthing hut, that clean room in the slum where you deliver on the floor with a TBA. But very quickly, people started to bypass it and go right to the hospital in Bangladesh. So the green is the hospital, largely Dhaka Medical College, for anybody who knows Bangladesh, which is just a crazy, wild place. Our Columbia Presbyterian can't hold a candle to this. And 30% to the delivery centers. But this is really, really interesting and important to see how quickly women from the slums are going from zero access to essentially bypassing the BRAC facility. So what's going on here? This has a mind of its own. What's going on here begins with this premise that the Manoshi Project is not just a biomedical intervention, although it was certainly that. But we need to understand this, and I would argue probably most other public health and health interventions, as a complex social intervention that is deeply embedded in the dynamic social, cultural, and political environment in which it's implemented. And I would say one huge key to understanding that environment in this case is the concept of informality. So in an informal situation, people do not have citizenship rights. Okay, so unlike the US, put the US out of your mind, in hundreds of other countries, the Constitution gives you a right of access to health care. A right to health is written in the Constitution. of hundreds of other countries, including Bangladesh. But in essence, the key point I want to make is that access to the resources of the city is not based on the rule of law for people who live in informal situations. It's very much based on contacts. And so the only way to access these services was to negotiate your way through a thicket of power dynamics that in slums are dominated by what are called mastans in Bangla, and that translates literally as muscle men, essentially organized crime, power brokers, political parties, religious institutions, various kinds of basically power networks that stand between people and services. I don't know, when I went to college, there's a famous book called The Poor Pay More. I don't know how many of you are in my generation and know these famous studies, but it was certainly true here. To access any services, electricity, water, sanitation, the poor paid more because they have to negotiate through this network of power dynamics. So the key to understanding the Bangladesh, the Manoshi success, I would argue, is not just that they provided a place for clean delivery, but that a health intervention created a link, created access to the resources of the city. And this was for people who came to the city with not as the dregs of development, the losers of development, as we often think of, I think, in this country when we think of slums. But these are people who came to the city with huge aspirations, with drive, with real aspirations to be modern. And what did they want from a city? They wanted access to the resources of the city. So I would argue that this is really the importance of an effective health program in a city. How does this fit into the global evidence? I think I don't have time to go to do this in any detail. I wasn't sure if earlier today people would talk about social capital and its relationship to health in cities. I'm sure some of my colleagues could talk about this extensively. But I think we can focus on the part of social capital, yikes, that here on this map of the sort of conceptual map of the social capital literature is called linking social capital. And basically, most of the literature on social capital talks about bonding social capital, about the strength of the ties that people make within their own homogeneous groups, like their families, their neighbors. And this is very much what was happening in villages, and why BRAC was successful in villages, in a kind of Paulo Freire model of conscientization. They helped communities bond together and basically strategize to take power into their own hands and change their lives. So most of the literature is about bonding social capital and so-called bridging social capital, which again is horizontal between two different groups, but kind of at the same position in society. The key here, I think, is to think of social capital also as linking social capital, as the way in which people traverse unequal hierarchical power relationships. And I would argue that what BRAC was doing with its Manoshi program, that in one way could just be described as a couple clean rooms in a slum and a transport to a hospital, is that they were giving people access to the resources of the city. And I think when we think about that, we can think about it in the context, again, I can't go too far, of the old, some of you may remember this idea of the right to the city that started in 1968 in Paris in the student demonstrations, but has recently been revived in global discourse around cities. So the idea of the right to the city, and that every person has the right to access the resources of the city and the city to benefit from all of its inhabitants. I knew this would be too small to see, so just, yikes, the skeleton of it is here. It's basically an attempt to take more or less everything that we do in urban public health and in perhaps urban architecture, urban studies, urban planning, from the social, the economic, and the political perspective. And the details in this are all the different kinds of projects that exist, but they overlap with, sorry, this is hard to see, but with that middle of the Venn diagram, which is access to the full opportunities of urban life. And I would argue that when we think of public health in urban settings, this is what we need to think about. And when we think about how it relates to urban planning, architecture, etc., this is what we need to think about. And I will ask Sandro whether I should or shouldn't show a 7-minute video that just shows this. Okay. Sorry, I didn't know it was going to be architecture time. So this is a 7-minute video made from the Menoshi program to give you a sense of actually, I think, yeah, what it, so you just click in the, you sure? I think it will. If you just click inside it. And the sound. There's sound. We tried all of this yesterday, it all worked. Okay, so
আমার নাম শ্রীমতী প্রভাতী রানী দাস। আমার বয়স 21 বছর। আমি 9 মাসের গর্ভবতী। আমি একজন গার্মেন্টস ওয়ার্কার। সবাই চাকরি করতে আসে পেটের দায়ে। এই পেটটা না থাকলে আর কেউ ঢাকাতে আসতো না। টয়লেট দুটো, ভাড়াটিয়া মনে করেন 14-15টা। একই টয়লেট ব্যবহার করতে হয়, একই গোসলখানা ব্যবহার করতে হয়, একই জায়গায় রান্না করতে হয়, একই চুলায় রান্না করতে হয়, মানে অনেক সমস্যা।
Urban slums, basic services like water and sanitation is lacking. There's no health infrastructure, right? And we felt that focus need to be provided to mother and children's health.
ঘরে ডেলিভারি হয়েছে প্রথম বাচ্চাটার। এই দায়িত্ব ছিল ডেলিভারি হবার সময়। এর আগে তো আমার পাশে কেউ ছিল না। মানে আমার ভয়ই ছিল যে অনেক কষ্ট যখন হয়েছে, সারাটা রাত আমি কষ্ট করছি, তখন আমার মনের মধ্যে একটা ভয় ঢুকে গেছে, এখন আমি মারাও যেতে পারি, মানে এরকম একটা ভয় ছিল আমার মনে। আমার এই বাচ্চাটা ব্রাক ডেলিভারি সেন্টারে হবে। এই অবস্থায় আমার ভয় নাই এখন, আমি নিশ্চিত, পুরোপুরি নিশ্চিত।
আমি এখানে থাকি, আমি 3 বছর ধরে এখানে কাজ করতেছি, মানে এই এলাকায় চলাফেরা করি, যে আমাকে সবাই চিনতেছে। প্রভা দিদি নমস্কার, কেমন আছেন? বাবা কেমন আছো? দাদা কোথায়?
কাজল আপা আমার একজন বন্ধু ধরতে গেলে এখন। কাজল আপা আমার সব সময় পাশে থাকে, আমি যখন তাকে ডাকি যে 1 মিনিট ফোন করার সাথে সাথে উনি আইসা পড়ে, যে কোনো সময় যে কথা বলি বা যে কাজটা করতে বলি সেটা সে করে, এখনো করে।
তার বাসায় আসার পরে তার চেক আপগুলো করি, যেমন তার রক্ত স্বল্পতা আছে কিনা এটা দেখি, জন্ডিস আছে কিনা, প্রেশারটা দেখি, তারপরে যে ফান্ডাল হাইট, তার বাচ্চার পজিশন, বাচ্চার হৃদস্পন্দনটা এটা, আর হচ্ছে পায়ে পানি আছে কিনা, ইডিমা আছে কিনা এটা দেখি। যদি কোনো সমস্যা হয় তাহলে সেক্ষেত্রে হসপিটালে পাঠাই। তার সব কিছুই ঠিক আছে, সব কিছু ঠিক আছে, তখন তার পরিকল্পনা করছি সে আমাদের ডেলিভারি সেন্টার ডেলিভারি করবে।
এই যে দেখেন বাচ্চাটা, ঠিক আছে, এই বাচ্চাটা কি হবে, বাচ্চাটা যখন বের হবে হওয়ার পরে ফুলের অংশটা আবার আমার পেটের মধ্যে থেকে যাবে। ইডিডি মিটিংয়ে যেসব মারা আসে তাদেরকে মোটিভেশন দেয় যে আমাদের এখানে ডেলিভারি মানে হইলে কি সুবিধা এবং বাসায় ডেলিভারি করাইলে কি কি অসুবিধা হবে, সেই জিনিসগুলো আমরা বলি, মাদেরকে বোঝায়। বিপজ্জনের মধ্যে যে কোনো একটা লক্ষণ দেখা দিলে আমরা হাসপাতালে মাটাকে রেফার করি, কিন্তু বাসায় যে দায় ডেলিভারি করাবে সে কিন্তু এই বিপজ্জনগুলো জানে না, যার কারণে মাটাকে বলতে পারে না।
We have developed a system that's called reference system, and we arrange a vehicle, the transport, to take that women to the hospital. And in the hospital, in fact, we have BRAC staff stationed there. They welcome those patients, they help them in a quick admission. This is really important in Bangladesh.
এটাকে আমি খুবই ভালো মনে করি, কারণ এখানে সব ধরনের সুযোগ সুবিধা পাওয়া যাচ্ছে, প্লাস স্মার্ট কর্মীরা এসে বাসায় আমার বউকে চেক আপ করে যাচ্ছে, সব ধরনের সুযোগ সুবিধা পাবো। এই কারণে আর কি আমি ব্রাকে কাট করছি বা ওখানে গেছি, ওদের সহযোগিতা নিচ্ছি, আশা করি খুব ভালো হবে।
মাকে গর্ভকালীন থেকে শুরু করে বাচ্চা হওয়ার পর পর্যন্ত সেবা দিতে পারতেছি, সেখানে একটা মায়ের ডেলিভারি করাইতে পারতেছি, একটা নতুন বাচ্চা দেখতে পারতেছি, সেই জন্য আমার চাকরিটা অনেক ভালো লাগে। সেখানে আমি কিছু টাকাও পাচ্ছি, তাছাড়া আমি মানুষের সেবাও দিতে পারতেছি।
খুব সুন্দরভাবে আমার ডেলিভারি হয়েছে, তারা খুব সুন্দরভাবে আমার সেবা যত্ন করছে, আমার বাচ্চার সেবা যত্ন করছে, মানে যেভাবে ভালো করার দরকার সেটাই করছে। বাপের কাছে দাও, আমার মেয়ে হয়েছে।
We are able to build up trust in the community that if they need any support, that we are there to provide support, and that's really important, you know, the trust building within the community.
ডেলিভারি হবার পর আমার সাথে সাথে ওনারা আসছে, আসার পর বাবুকে দেখছে, আমি সুস্থ আছি কিনা আমার পরীক্ষা করলো, তারপর বাবুর টিকা দেওয়া লাগে সেটা বললো, বাচ্চাকে এখনো বুকের দুধ খাওয়াই।
Most people we serve are very poor. They don't have to pay us for the services that we provide. Sometimes when we refer them to hospitals, some money may be needed for drugs or particular operations. But if the family is unable to pay, BRAC pays for it.
নমস্কার, আবার কোনো সমস্যা হলে ফোন দিন কিন্তু। আচ্ছা,
সোনা দিয়া বান্ধাইয়াছি ঘর, ও মন রে গুনে করলো জর,
Hi there. So thank you so much to Columbia's Schools of Public Health and GSAP for inviting me here today to share, and I think some of the experiences on the research translation side. So this is about taking the evidence that's produced by research, such as the ones occurring here at School of Public Health, and actually translating it into city policies and actions. So I'm going to share some of my experiences there, both here in New York City and elsewhere around the world. So I'll start, I think, just as we started discussing public health history at the very beginning, about Columbia's history, and it's the history of its programs. Similarly, the research translation and the intersection of health and architecture and planning and urban design really has this whole historical basis as well. So in the 19th century, the major causes of death at that time, infectious diseases and all of those epidemics like cholera, were functionally addressed using built environment measures that required the participation of architects and of urban planners and urban designers. And today, of course, we've got a different set of diseases. As Carlos presented, chronic or non-communicable diseases. And we can actually think of many of these diseases because of the links to nutrition and to physical inactivity as actually diseases of energy, right? And so because of that, there's this fundamental link, of course, to our environment and to the crises of energy that we're experiencing, right? So when we don't move our own bodies and when we're consuming a lot of unhealthy calories, we're actually consuming energy and not actually expending the energy that we need to create health. And so we're going to talk about, I think, some of the design solutions as well. And you heard some of the evidence from, Gina and from Andrew and from Carlos. So, going back in history, if you use New York City as an example, but this is really true of many of our cities and urban areas. If you go back to the 19th century and early 20th centuries, the environmental conditions of that time were actually breeding grounds for the types of epidemics that we saw. Overcrowding was rampant and is still rampant in many of the slums around the world. So in lower Manhattan, we had basically densities approximately double that of what we see today. In some of the wards, they actually reached over 400,000 people per square mile. So that's 6 to 7 times what we see today in terms of Manhattan. And then coupled with that, you had inadequate systems for garbage, for water, for sewer. So if you look at, the history books and what they say about our drinking water supply, it came from a downtown pond, right? That frequently had dead animals and garbage floating in it. Buildings were very crowded together and setbacks were minimal. And so light and air couldn't really penetrate our streets. And you had dark, dank streets with puddles that would breed mosquitoes. And so the types of diseases that we saw were spread by crowding, like tuberculosis, waterborne diseases like cholera, mosquito-borne diseases like yellow fever from all of those puddles. And so what did we do? In the 1800s and early 1900s, we didn't have medications like antibiotics. Penicillin, the first antibiotic, not discovered until 1939. And so the response was to actually built environmental interventions after multiple cholera epidemics. In 1842, New York City moved its water supply from the downtown pond to the Croton Aqueduct, which remains today our water supply for New York City. And almost immediately overnight, those cholera epidemics went away and they never came back. 1857, Central Park was created, hailed as ventilation for the working man's lungs. So now, regardless of whether you were wealthy and had your own little courtyard, or you didn't, and you lived in a crowded tenement, you could go to this public space and actually get sunshine and fresh air and exercise with your family. 1881, the Department of Sanitation was created, started cleaning our city streets of, all of the garbage, dead animals, horse manure that would pile up, that actually required those second floor entrances, right, of those brownstones. 1901, Tenement House Act was passed and actually banned the construction of dark, airless tenement buildings. So all of a sudden now, buildings had to have windows, whether they were wealthy buildings or, the tenements. And now light and air could circulate into the buildings and there was ventilation. 1904, the first section of the subway opens in large part to deal with that very severe overcrowding in lower Manhattan. Population could now spread out to northern Manhattan, to the Bronx, and travel quickly to the areas of commerce, which was still in downtown Manhattan, and into areas of work. And zoning actually also required in 1916 buildings to be stepped back. Now light and air could enter those streets. Those puddles dried up. Those mosquitoes went away. And this is what we saw, right? The drops in infectious disease deaths from nearly 60% of deaths in 1880 to by 1940, prior to the availability of widespread antibiotics, 11%. Of course, medical technologies have continued to improve between 1940 and today. And, you know, we have tons of antibiotics now. We've got other treatments, new vaccines. But yet you see that the major gains were made during this era of sanitation for the diseases of the previous century. And of course, we continue to make gains to 9% of deaths today, but major gains made prior to medical treatments. And so today, the epidemics of today are non-communicable. They're no longer those infectious diseases. Even in the developing world, heart disease and strokes have overtaken infectious diseases as the leading causes of death. They are now the number one cause of death globally, 36 million deaths per year. And the leading risk factors accounting for 80% of these deaths, tobacco use, inactivity, unhealthy diets, harmful use of alcohol, are actually preventable. So the rest of my talk is going to focus a little bit more on the inactivity and unhealthy diets components. I think, you know, in a place like New York City, we've made a lot of gains in the previous decade on tobacco. We continue to make gains. But I think, you know, under the previous administration under Mayor Bloomberg, a lot was done on the physical activity and healthy food items. And so I'll talk a little bit about that in this case study. And, you know, you've heard also about the evidence base and the growing and in many cases ample evidence now around the importance of neighborhood, street, and building designs and forms in addressing these issues. And we can think of, I think, you know, in terms of design and forms, the three elements and three parameters that we want to try and increase in daily life. Active transportation, because that's a part of everyone's daily life, right? Whether it's children getting to school, adults getting to work, running errands between hours of work and home. So that's a really critical piece that we can address. But then, you know, people do have leisure time, and are there things that we can do to shift to more active recreation also in leisure time? And there is evidence suggesting that if you have increased access to things like parks, and how you design your parks and playgrounds also make a difference in terms of the amount of activity that you might get outside of work time and transport time. And then in our buildings, we do spend the vast majority of our time daily in buildings. What can we do as well to increase active movement within buildings? And you know, this collaboration that has occurred, for example, in New York City over the last 8 years, and the work that's been done on policies and practices and implementation at the city level. I mean, what we've seen actually are a lot of ideas, design ideas and form ideas that come from, I think, designers and urban designers and architects and planners that health people like myself could never have conceived of on our own, right? So for example, you know, when health people are doing interventions to look at what will improve stair use, they'll put up a sign with health messages, right? And of course, that shows that, I mean, there's multiple studies to show that that works also, and it's inexpensive. But when we started working with designers said to us, you know, aesthetic elements are really important. And it's not just about, you know, putting some pictures up on the wall in the stairwell. You might want to think about where you locate the stair, the aesthetic elements leading you to the stair. You know, aesthetic elements in stairs, like, do you have natural lighting? And so, you know, we've begun to actually undertake now both interventions and interventional studies that show that. So, you know, we were able to, through our city buildings that have opened up stairwells, look at whether stairwells that had natural lighting, whether those were associated with more stair use than those that were not. And in fact, of course, they were. And it was architects who told us that. And, you know, we did a simple study and were able to show for the first time in the literature that natural lighting is associated with increased use of stairs. So this collaboration between the sectors is actually a really critical piece of making advances, I think, in both the research, but also the interventions that are needed in the built environment. And then we've also talked about healthy versus unhealthy food, and that balance, right, of availability of healthy food sources and premises that might give you access to healthy fresh food, like supermarkets and farmers markets and community gardens. And then at the same time, literature increasingly showing as well that unhealthy food exposure through, for example, things like fast food outlets are associated with poorer diets and increased weights. And in terms of policies and practices, I think, as Carlos was saying, more does need to be done around interventional effectiveness. So there are policies that are, starting to occur. I'll talk a little bit about FRESH, which are incentives for supermarket creation in underserved neighborhoods here in New York City. But there are other cities like Detroit, for example, that actually has zoning laws preventing fast food outlets in the immediate vicinity of schools, right? I think very often, though, when you don't have that conversation between zoning and health, or transportation and health, or architects and health, then things that are done not necessarily for the purposes of health are not necessarily evaluated for the health outcomes. And so this conversation, I think, is a really necessary one. So the bulk of my talk is going to actually focus on, integrating health into urban and building design policies and practices. And from the experiences here, both in New York City and with the other cities that I've worked with, what are some of the things that are critical elements of that? I think today really demonstrates, the importance of partnership across sectors. Because of course, those of us in health might be able to show you some of the health evidence that we can garner from the literature, but there's no way that we can shape the built environment. We don't design it, we don't construct it, and frankly, we don't know the policies in it and what the policy mechanisms are within it. And so this partnership actually is the critical element to actually making the changes that we need to see at the policy and action levels that create interventions and change. Additionally, I think this has also been mentioned by a number of our presenters. We're talking about benefits that extend beyond health. And when you look at political context, politicians, communities, societies, often health is a very important value, but it is not the only value, right? People also care about issues like economic development, the environment, equity issues. And so finding synergies and co-benefits have been really a critical part in terms of advancement of these issues in the communities that I've worked with. So identifying those co-benefits as much as you can so that different stakeholders that might have different interests or different stakes can buy into the similar interventions which actually create these multiple outcomes. And there are very important complementary roles of the partners. So folks like myself in health, we can present the data, the evidence. Researchers in health can help actually with the evaluations of interventions, can help to synthesize the evidence needed to actually make the case for specific planning or architectural interventions or policies or practices. But really the ideas, for example, in a city like New York, the ideas for what's feasible in terms of policy in the local context has to come from the people who work within their sectors. The planning, transport, parks, public works, housing, school construction, architectural, buildings, parks, recreation sectors. Because you guys know what's best, like what's occurring in your sectors within the local context. You know the politics within that local context of what can actually move and what might have no saleability. And so identifying those opportunities and mechanisms and the policy tools that you know about within your sectors is actually the critical element in making those changes that actually result in feasible change within our communities. And it's really vital because of that the different sectors actually play co-leadership roles, right? So, and depending on the initiative and the intervention, it doesn't need every sector all of the time, but it needs several sectors, at least for each of the initiative. And researchers, with us have played a really critical role in evidence synthesis and generation, and also in evaluation research when interventions are occurring. evidence-based and best practice design strategies. So, I'll talk about the active design guidelines in a second. But with the active design guidelines, it was an attempt to really take the evidence that was present in health. And when we actually did a survey with support from Robert Wood Johnson Foundation, got some funding to do a survey of architects and of designers in the city, what we heard was that 30% of architects and designers utilize research journals as a source for inspiration and a source of interventional change. But over 50% of them, 56% utilizes guidelines. And so guidelines are a way to reach the majority. But then what we actually heard was, 86% of them actually told us, and some of you actually told us, that continuing education seminars provided by your professional societies were the major way in which you utilized, in which you got new knowledge and integrated in new practices. And so, in addition to the guidelines, once the guidelines were created, one of the things that the health department did was it actually went out and got another grant and actually worked with our other city agency partners to create a series, active design trainings, actually, active design guideline trainings that architects and planning professionals could access. And over 3,000 professionals actually nationally have been trained through that grant. And so anyways, and forums like today are actually a really important piece of moving from research to intervention, and then also connecting innovative interventions back to research, right? Because it's these forums that allow for the cross-sector dialogue, researchers to practitioners and policymakers, and then across different sectors as well in content areas. So, other examples of such forums, in New York City, we've had annual Fit City conferences since 2006. And similar conferences, I've been involved in helping create similar conferences for these cross-sector dialogues also in San Diego, Louisville, Boston, Miami, a number of Canadian cities. I see Sky Duncan in the audience, and Sky, who's actually a city planning colleague with me, but she also teaches urban design in GSAP. She's also been involved with, helping London and Sao Paulo in mounting Fit City conferences. In fact, with me, and she just got back from Sao Paulo. They had their first Fit City Brazil conference, actually. And I see Carlos in the audience, and I actually want to say, with the number of cities now mounting these conferences, maybe we need to have a Fit World conference that in Geneva that the WHO can spearhead, maybe in conjunction with Colombia. U.S. cities built environment and health initiatives. So this comes from a grant from the CDC that actually gave New York City Health Department some funds to create a peer-to-peer mentoring network across 15 US cities. And you could see the cities are actually quite varied, East and West Coast, very suburban places like Cook County outside of Chicago, to major cities like New York and Chicago itself, Boston, Philadelphia. So some of the older cities. And then even tribal nations like Cherokee Nation in Oklahoma. And so this is to say that, these types of initiatives are actually feasible across different types of typological contexts, right? Because sometimes I'll get the question, well, you live in a very urban area like New York City, so I'm sure that's feasible there. But it's not going to be feasible in a rural area. Many of these departments that we actually worked with were county health departments. So a place like San Diego, it actually had 18 local municipalities. They had unincorporated rural areas. So the types of initiatives focused on, of course, varies by the local context, which is why it's so important that the different stakeholders in each city actually get together and actually have dialogue, because the solutions need to be local and they have to be geared towards the political context. But the process by which we bring those stakeholders together can be recreated, and it's being recreated. And we can, I think, do more of it in more cities around the world. And I think this is particularly important in areas that are rapidly urbanizing, because so much of the urbanization that we're seeing in Asia, for example, in Latin America, are still unplanned. They're still because it's occurring very rapidly, right? But I think one of the things that we learned here in New York is that we get told all the time by architects, like myself in health, for example, architects, and by urban planners and designers, that if this had been on their minds, and if it's on their minds as they start the design process or the planning process, it can be integrated very easily. It doesn't have to cost a lot more money, but it's out of sight, out of mind. And so those conversations, like today, are key. These are the types of partnerships that we're seeing across these US cities that I mentioned. Public health planning, transport, school construction and education, parks and rec, public works, housing development and management, particularly around social housing and affordable housing, and the Department of Buildings where necessary to address, for example, building code impediments that might be there. And the partnerships, of course, extend beyond the government agencies to nonprofit groups, environmental organizations, speaking to, of course, the synergies with environmental sustainability, local professional societies like the planning associations and the Institute of Architects, landscape architects, design institutions and academic institutions have been key. So, you know, if we take New York City as a case example, just to pepper it with, you know, the types of things that have been done to give you some idea. Of course, many of you probably have already seen the things manifest in the communities. We've talked about the active design guidelines. It really was a result of the collaboration of 12 city agencies participating, in addition to additional groups giving inputs and feedback. This collaboration was actually co-led by 4 agencies, right? Health, Design and Construction, which is our public works agency, transport and planning. And so it really demonstrates that, you know, processes that involve multiple government sectors are possible. You actually have to have concrete outcomes that you're working towards, you know. So it's not just dialogue for the sake of dialogue, but in fact, you want to create concrete products that can be put into action. And the types of things that you're seeing associated with the active design guidelines and that are being manifested in terms of policies and practices include complete streets and bus rapid transit that you see on more and more of our streets. And of course, these are ideas that are not unique to New York City. They're borrowed, like bus rapid transit really comes from Latin American examples in Curitiba and in the Transmilenio in Bogota, which really gave us examples of low-cost ways of expanding rapid public transit without having to dig into the ground and dig into the, to create rail, which takes a long time and is very costly. Public plazas program. So many of the initiatives undertaken in New York City have been actually, have cost very little money in that, and they're very quick to do in that they take plant potters, they take paint, they take street furniture, and they take political will, right? And so, and because they're so inexpensive and quick to create, one of the opportunities of initiatives like this is it allows for piloting, right? And piloting can sometimes be a gateway to something more permanent. So for example, even bus rapid transit routes, right, requires no digging. And so you paint a bus lane. If that route isn't working, you can always repaint it, right? Doesn't cost much, and you can put it up immediately. So people don't have to wait years to experience that public plaza or to experience that new transit system. They can experience it immediately. And if it's designed well, usually it's a good experience. And so the support really during the pilot phase will pour in, and that's the support that you need to make it permanent. The other thing as well is concerns should not be concerns. For example, with the Public Plazas program, a lot of concerns when Times Square was being created from the retailers that they would lose business. And so one of the key outcomes that transportation in New York City addressed was collecting data on economic outcomes, right? And so in addition to looking at pedestrian volumes and walking and air quality, retail outcomes were also measured in a number of the pedestrianized areas. Times Square, for the first time since pedestrianization, is now in the top 10 retail areas in the world. Wasn't able to achieve that prior to this. 49% drop in vacant storefronts around the pedestrianized areas in Union Square. So those issues that become concern, if data is collected on it, it can actually very well become a strength that actually helps to solidify the program. This is, the wonderful work of Skye Duncan The health department, as part of its peer-to-peer mentoring activities, got some funding to actually that we shared with city planning, and city planning was able to actually go out to different cities around the United States to look at the best practice sidewalks, and has actually quantified design-wise, although, Sky and I were talking earlier about, talking to Andrew and Gina about how we can quantify this in a sort of for health-related studies. But anyways, from a design perspective, attempted to quantify and qualify those aspects of sidewalks in different types of geographical neighborhoods that seem to encompass best practice sidewalks. So that's available on the city planning website. Bicycling infrastructure, of course, you've seen that in bike share, in bike parking, and in bike lanes, including indoor required bicycle parking now in new buildings, whether commercial or residential. That's part of a zoning change. Zoning, health, so planning, health, and economic development got together to actually look at our food desert neighborhoods, which are also, of course, our neighborhoods in need of jobs. And financial, so tax and zoning incentives were created to actually incentivize the development of these supermarkets. And, we know that, 3 supermarkets have opened to date, and there's 11 more in the pipeline that are in creation now. And this program, this work, this initiative just began in 2008. So in a matter of a few years, you're able to actually make a difference. And these incentives, of course, economic development got involved, not because merely of the health issues, but because they wanted to create jobs. And the new supermarkets are also creating thousands of jobs. And then thinking about, as part of your mixed land use, of course, amenities like public parks and open spaces, including waterfront usage, where you can, on the water, in the water, and around the water, for transportation and recreation corridors. And thinking about, I think, our public spaces, including our streets, not only for automobile uses, but as a democratic amenity that allows for choice and allows for multiple uses. So part of that, of course, is the complete streets, but on a more permanent basis. But on temporary basis, also closing off streets like Park Avenue, 7 miles of it during summer streets in August, on Saturdays in August, to allow for people who might not otherwise use the street in a different way to experience the street for cycling, for skateboarding, for recreation activities. So even though these temporary measures may not permanently change the landscape, they can actually help to also induce cultural shifts and an experience of the built environment that's different from, for example, only being in the car on the street. Okay, and I need to finish up very soon. So stair promotion, so just to say that thinking about the interiors of our buildings as well as the exteriors of our buildings, using mechanisms like green building credits that can create mechanisms that are familiar for architects. So there's actually now a LEED pilot credit called Design for Active Occupants. So if you're designing, and there's an opportunity to use that and get an extra point. And the last few slides merely say that this is not occurring only in New York City, but seems to be, I think we're at sort of perhaps at a tipping point where different cities around the world appear to be interested in these issues. I think we've been talking about climate change and environmental sustainability for a while. WHO has been, for the last decade talking about NCDs with that summit at the UN a couple of years back, emphasizing the important role of NCDs. So I think we're starting to see sort of a more and more interest globally. So Canadian cities are doing this. Australian cities are doing this. There are select, I think, Asian cities that are doing this. But there's still a lot of unplanned growth that I think we need to help to deal with, particularly when cities are growing from the ground up. There's such an opportunity to build it up the right way, because to retrofit this probably cost a lot more than to have left the river open in the first place, right? And to create those amenities that include the car, but also recreation and active transportation, sustainable transportation amenities. And then, of course, Latin American cities like Sao Paulo that are having this conversation, but examples that we have learned from, like the Transmilenio And, this is bike lane in Bogota. And then, of course, the multiple benefits, right, beyond health, including the environment, accessibility as populations age particularly. So if you can't drive anymore, if you can walk places and move, you can still go see your neighbor, you can still go buy groceries, you can still go to the bank. And, frankly, economically, it actually makes the most sense to build cities that are healthy because infrastructure costs of more compact, walkable development patterns save money. And so, for those concerned with costs, this is actually a reason to do this. And then, of course, multiple impacts. In a place like New York City, you could see the various impacts from safety to physical activity to reversing the childhood obesity epidemic for the first time and the economic and positive environmental impacts that I also showed. Thank you.
So I realize that this panel is between us and lunch, but I want to capitalize on Dr. Lee and Friedman's expertise for just 5 minutes. Let me lead off with a question, and then we'll take questions from the audience. We've heard a lot this morning about the physical environment, which in some respects is a natural because we are dealing about architecture, urban planning, but in much writing in public health, there is this notion that there's the physical environment and the social environment. And in both your work, it was implicit that the physical environment is influencing aspects of the social environment, things like social capital, social interactions, social norms. I was wondering if you can both be more explicit about that and talk a little bit about where the intersection between public health, architecture, urban planning lies in shaping social environment to promote health.
I think there are various sort of aspects of this. One is, of course, that the built environment itself can influence what happens in the public realm, right? So, for example, if there are no spaces for people to actually interact with their neighbors, whether it's in their buildings, in a multi-residential building, or in the community, such as having, playground space where their children are interacting with each other, or pedestrian plaza spaces where people might be sitting and meeting their neighbor, then there's actually those opportunities for social capital are actually diminished, right? So I think the built environment itself can directly influence the social environment and socialization. The other, of course, is that we're hearing, I think often, right, one of my questions is how do we measure multiple co-benefits at once when we're doing interventions? Because very frequently, I think, when we're thinking of a research project, we'll measure sort of a specific outcome. The research group will measure a specific outcome of interest to that specific research group. But if we can actually partner across research groups, right? So, health outcomes, but maybe sociology outcomes, environmental outcomes, usually it's going to require actually a collaboration of different researchers, either at one university or at multiple universities, to actually collect those outcomes and to have enough expertise to collect all those outcomes. So I think more of that can be done as well. Like, for example, when we have instituted the Play Streets initiative, which are, an adaptation of the summer streets to single blocks of streets in high needs neighborhoods that could be closed off, weekly or even daily throughout the entire summer for kids and families in underserved areas to play. We've been measuring things like physical activity, watching television, like when we survey the parents. But they're telling us anecdotally that they're seeing, they're seeing good social outcomes, right? So the organizers will tell us, we're seeing a lot of kids in grade 5 and 6 come to this. And that's really important because, a lot of these kids might fall into gang activity if they had nothing to do. And so I think thinking more comprehensively probably about evaluations to capture the multitudes of outcomes within one intervention is a really important piece.
I think I'll give an answer that's sort of bigger questions of how urban planning manages these huge informal spaces and the slum populations that live in them. So I kind of have this, I think there's this basic challenge of this sort of physical interaction between these populations and the people who are the legal residents, shall we say, of cities. And so the way in which the city is planned to either incorporate, benefit from, give access to these marginalized populations is in part a question of physical planning, as well as, I think, a social dynamics question. And the result is not just poor health. I mean, in many ways, the result is the huge political conflict and, really dangerous situations that are happening in many countries where people come to the cities with huge aspirations and ideas about how to be part of what's happening in their countries. And when they are made invisible, when they live in the so-called hidden city and excluded from access to anything, to the resources of the city, this contributes, I think, to the kind of political violence and bigger questions of communal, the South Asian word is communal conflict between communities. And so I think there are really fertile ways in which we can think about, I suspect there's a whole world of writing and so on in urban planning about these questions. But
Can I just add one more thing as well? Because I think when you were talking, Lynn, it just sparked one more thing, and that is, over the last couple of years at the health department, my program's also been involved in doing community design workshops around the active design guidelines, where we work with nonprofit groups and local community groups to bring together community groups that are active within the community, but also community residents who might be interested in brainstorming together potentially specific neighborhood solutions that might be feasible to do within their neighborhood around improving the built environment for physical activity and healthy food access. And I think many times the conversations that we might have with community members may not necessarily set the stage for an informed discussion. And so, for example, I've gone to sessions where, before we began these workshops, some charrettes, for example, where, community members would just ask, well, what's important to you as we redevelop this area? And, invariably people would be like, parking, like, don't take away my parking, and stuff like that. But when we have these community active design guidelines workshops, where we frame the conversation from, this is what we know from the research, these are the potential benefits that could result from these types of interventions, the conversation takes a very different tone, right? And people are actually working collaboratively to see how they can balance the need for parking with the need for active transportation and sustainable transportation and active recreation spaces, for example.
Let me ask my second question, which builds on what you just said, Karen. So what are your thoughts on health as a value, and health as a value that we can leverage to promote the construction of cities that are not just health promoting, but also aesthetically pleasing, that meet several other criteria? It's certainly my impression that health is one of those very few universal values that cross cultures, cross countries. One can argue about many other values that countries hold dear, but it's hard to find countries which do not value health. And so how do we then take advantage of that for other purposes that go beyond health?
I think, in all of the places that I've worked with, Chandra, usually when we begin the engagement process, so I'm usually working often with their health departments, and then the health departments I'm working with them to, create processes for dialogue with other sectors, right? Whether it's a forum like this or a Fit City type of forum, or just specific meetings with specific ministries, right? And the types of things that I hear and that you get reaction to from other sectors is frequently, because, for example, good urban planning is often very synonymous with the types of things that we want to do, right? The folks who are actually very interested in environmental sustainability within their community is very interested in very similar things, right? And so often, one of the reactions that, we'll hear is, oh, we're so glad that you've come to the table, because we really want to use health as an argument, because we know the public values health. And when we talk about the environment, not everyone values that necessarily. When we talk about aesthetics, some people don't value that. And so the reaction has almost always been positive from the other sectors at using health as a universal value that could be leveraged to actually create the types of changes for synergistic and co-beneficial outcomes with health and beyond health.
I think others can use health, but health can use others too, use other values. So when a health program has in it more than just, physical health outcomes, but the kinds of things that I think even unintentionally programs like the one I talked about are doing, they can become vehicles for other values like, active citizenship or things like that. And I think they are wedge programs that, people like me who work on human rights can just kind of pull this into a program, into a health program, in ways that you can't do if you are in your face about human rights.
That's a neat point. Let's take one question from the audience, maybe 1.5. Dean Fried.
Sorry, thank you all for really exciting presentations. I wanted to ask a question about water. So in many, and perhaps link back to what you were saying, Karen, about guidelines and Leeds criteria and whether they work. So in many parts of the world, we are verging on water as an emergency. Safe water, access to water, not wasting water. There are huge numbers of innovative technologies, but it would to use them require building them in not just into building codes, but into investments at the levels of cities and regions to work together to change how entire civilizations use water right now. How do you accomplish that?
I think the answer is going to be so dramatically different in a place like Dhaka, since that's on the line, where there is no comprehensive urban policy. They literally don't have one. They don't have an urban, it's not even clear what ministry has the control over or authority over urban health, and in fact it's a huge battle. So all the advances on water have been made by NGOs, non-governmental organizations, and have not been really, in places like Dhaka, not really part of, thinking citywide and comprehensive planning, although to say it's an emergency is an understatement for a place like Dhaka.
I was going to say, I agree that I think the issues are so varied from jurisdiction to jurisdiction, and the sort of policies are also so varied that I think you need to have local context sort of solutions, right? But I think that, I don't know, just based on my experience in working with different cities on these issues, I think if you set up dialogue in such a way that brings together the right stakeholders and have them have that conversation, local solutions can be found. Now, it may not be the ideal solution immediately, but it could be small steps that would eventually lead to bigger gains. And in some places, you may make very small steps initially. In other places, maybe you can make bigger steps. But I think that bringing together the sort of a group of different sectors to have that dialogue with a framing of the problem, not just globally, but within their local context, can start that dialogue.
I suspect we can actually keep going for a while, but I also feel like we all need a break and some food. So first, please join me in thanking Dr. Leanne Friedman for this panel.